like to welcome the second speaker, Dr. Waleed Alharbi from King Saud University. He's the Director of Adult Cardiology Interventionist. He's a structural heart disease interventionist. Now we will discuss the opposite to severe asymptomatic. So now we have a patient who is symptomatic but with less degree of severity. They have moderate aortic stenosis. Go ahead, Dr. Waleed.
And heart failure.
Assalamu alaikum jami'an. So I'm going to talk about a topic already touched base by Dr. Eberhard and multiple of my colleagues about the challenges that we might face from diagnostic and therapeutic approach. And the first question to answer that, when to going to fix moderate aortic stenosis with heart failure, reduced ejection fraction? There is no definite data, there is no guidelines, and the only guidelines that address moderate aortic stenosis was only if patient going for a surgical procedure, concomitant, and then you have moderate AS, then you proceed for replacing the valve. That's the only one in the guideline. And I had a case that I was going to present it with a moderate aortic stenosis, HFrEF, admitted 3 times within the last 6 months, and then eventually, it was a mistake that we labeled him as a moderate. Actually, he has severe aortic stenosis. We did TEE with 3D planimetry. It showed that it was actually severe, and that's make me question how we answer the question to inform our decision about moderate AS with HFrEF. And to summarize it in 4 questions. Is the diagnosis correct? As the case I had. What's the patient life expectancy? What's the procedure risk? And will it help to take out the moderate aortic stenosis from the equation? So is the severity correct? And that's what addressed by my colleagues about it, Dr. Ahmed al-Shehri and others. There's a lot of confounding factors we face, and the imagers know that very well, is that you might fail to optimize windows, and that go to 20% patient being underdiagnosed. Third of all patients who have severe aortic stenosis have discordant echo measures. And that's where we go with the algorithm to find out where the patient lands, whether from severe or in a low flow state and moderate aortic stenosis. And if you have a combined pathology, when you have aortic regurgitation, most of the time, if you have moderate AS indices and concomitant moderate aortic regurgitation, the likelihood that patient has severe aortic stenosis. Then you say, let's use another modality, again, help us in our decision making, like a Gascon calcium score for the valve. It's very concordant with severity, but the issue that we have a higher percentage of bicuspid. For example, in India, it's about more than 40%. They have bicuspid pathology with severe AS. And I believe, hopefully, there's coming data kind of shows how the prevalence of bicuspid in our region. And also, we have a lot of thrombotic entities that cannot be applied the same concept. And we have to remember, sometimes if we have 1 centimeter square aortic valve area, actually the standard deviation from the Doppler echo data studies, it's actually the standard deviation goes to 0.1 to 0.115. So remember that if you're in the borderline, lean forward in the severe aspect. And this is a very good review paper where they approach moderate aortic stenosis, and that's what we talked about, how you don't fall on the pitfall, like in our patients that we labeled him moderate, and eventually he was actually severe for the last few months. The next question I would ask is, what's the actual life expectancy if patient have HFrEF with moderate aortic stenosis? And the studies showed that once you have cardiac damage, as my colleague mentioned about it, actually, if you have HFrEF with moderate AS, they're very sensitive to afterload. the actual mortality increase dramatically. And you see the difference in moderate to severe, they're very close in mortality compared in mild aortic stenosis. And since then, their studies came out. For example, a recent paper, rather than looking at the stroke volume, you try to look at a flow rate. And there's a transaortic flow rate equation, and it was well correlated with outcomes, as we've seen in the aortic V2 jet velocity. And it showed that it's less than 218, which is a good index to use in those patients with moderate aortic stenosis to help you in risk stratifying your patients. So what are the procedural risks? We know from the trials of the TAVR and balloon expandable, self-expandable, the success rate is high and the safety profile is very lucrative. And also we saw that in the TAVR unload trial, also it was no much harm compared to the control. That gives you an idea that TAVR probably is a good option if the CT and other comorbidities are suggestive of a safety net for the patient. And the last but not least is, will TAVI help in that patient? And the only randomized trial that so far we have is the TAVR unload. And it's been talked about. And I just wanted to have an idea about the inclusion criteria that have been used in that study, where they made sure that the patient is a moderate aortic stenosis, because this is the major pitfall of underdiagnosing severe aortic stenosis. And then they randomized them to goal-directed heart failure therapy with TAVR versus only medical treatment. And as you know, it did not show superiority, but the trial, I respect about it, is that they really used a hierarchical composite outcome rather than the usual composite endpoint where you don't have the same weight of different primary endpoints. And it did not show a difference, superiority compared to medical treatment at 1-year follow-up. The issue with the trial is underpowered due to difficulty in recruitment. In addition, the issue of recruiting people and the power is really, sample was low, and that's what the other trials, which I'm going to mention, that trying to address that. But at 1 year, if you look here, we look at the symptoms, why, in 1 year, and early on they separate, but they really converge again at a 3-year follow-up. And what they did is that, why I'm mentioning this, because I'm going to show you the other trials that's coming, is that they use a hierarchical composite outcome. So they give a weight. For example, death is not equal to hospitalization, right? And that's how, rather the conventional way, they use the hazard ratio, they use the win ratio, and this is really helpful so you know exactly your the weight of the treatment effect on the patients. I'm just going to skip this. And the two trials that's coming to answer this question is that they didn't use an hierarchical composite endpoint. So we have to put it in mind that when we interpret the data. But hopefully those two trials will answer the future question about the utility of moderate aortic stenosis intervention in those cases. And I believe the vision might come, if became positive, is that TAVI in a context of moderate AS, it might be, as Philippe Généraux coined, is that can be the fifth pillar of management of HFrEF patient with moderate aortic stenosis. So in summary, there's no definite data so far. You need to make sure, clarify that aortic stenosis severity, it is moderate before you label that. And if it's really clearly severe, then understanding the pitfalls of imaging will help you to define which phenotype does the patient have. And selected patients, whenever you have an evidence of a cardiac damage in context of moderate aortic stenosis, you individualize that. For example, if a patient had recurrent heart failure within few months, and you did everything you can with medical treatment, and you're sure it's moderate aortic stenosis, you want to take out that from the equation to see if patient going to improve with that until we have further data. You have to assess the procedure risk before you embark on that strategy, and assess the likelihood of a second valve in the future is low before you do that. And with the new coming trials, hopefully we're going to have more knowledge to answer this question. Thank you.
Thank you, Dr. Waleed, for this nice case presentation of this interesting topic. I would have one question before I pass you on to my colleagues. Since this is not the moderate aortic stenosis with heart failure or symptomatic moderate aortic stenosis, is not an entirely benign condition, as you alluded to and you show us in your slides. And there is many other studies, observational studies, that suggest that moderate aortic stenosis carries a lot of mortality and morbidity. So why do you think these two studies failed in showing, or the main study showed that there isn't much really in terms of mortality and morbidity benefits? It's only just mild benefits in terms of quality of life.
We have to remember that it's observational studies. It's confounded with other factors. But I believe, even if it is negative, I think if they phenotype the patient better, those with cardiac damage, and you want to take out that equation of afterload for those patients with HFrEF, I believe it might, example like Tri-Illuminate and the TriClip, they show a benefit in hospitalization, not mortality. I think that's the case might happen on moderate aortic stenosis. I think so. I'm not sure about it, but I think that's where we're going to head, that minimize symptom burden and frequent hospitalization rather than mortality compared to, unless we have the trial says otherwise.
Any other question from the
No, I
list?
think go ahead.
Thank you very much, really. It's a very nice presentation. It's really, I am a bit confused. I have got a clinic on next Wednesday, and we have trained quite a few family medicine doctors, and they are good at picking up murmurs. And one of them has seen a patient who is 95 years old with the ejection systolic murmur. They have done an echo, and they found he has got severe aortic stenosis. He has a good quality of life. He's going to the mosque with no problems, enjoying his life with his wife and his kids, nephews, and nieces, and he sent it to me. What I'm going to say to this, who is now qualified as patient in clinic, I'm going to do something to investigate things further. He's totally asymptomatic, good quality of life, but from the evidence which I can say, something needs to be done, or we have to just wait and see what's happening.
So you're talking about asymptomatic, severe aortic stenosis?
Stenosis, yes. Good quality of life, 85 years old. And when I think if he's my dad, and I remember what are the complications which may happen to him, then I have to think carefully.
Dr. Ahmed
will answer that.
Yeah.
So this is exactly my dream, as I mentioned. So my dream is to try to pick those patients who will have trouble. So probably in the future, there will be multi-parametric imaging criteria, including the echocardiography, like strain imaging, plus the usual echocardiography, ejection fraction, left atrial enlargement, pulmonary hypertension, plus all these things. And then strain, and include also the MRI, T1 mapping, delayed enhancement, extracellular volume. We can include them. My dream is to have an AI that will make it useful to try to beyond just the ejection fraction or beyond the valve area, beyond the the gradient, that you can say those patients, if they have more damage they are more likely to benefit from early intervention.
I think for the sake of the time, maybe one more comment, and we have to move on to the next speaker because we're really running out of time, you know.
Thank you very much for the presentation. My point again for this asymptomatic severe AS, whether I think with the early TAVR data, first of all, they did not compare that to the optimum treatment, which is SAVR, this
Sure.
number one. And excuse me. And number two, the benefit was only with symptoms related to heart failure. It's not true heart failure hospitalization. So we are here dealing with what we call phase healing with subtraction anxiety. The patient who received the valve got the phase of healing, and he will not complain of dyspnea and not present to the... And the patient who did not get the valve will feel short of breath and will go to the ER and get this subtraction anxiety. So I don't think the early TAVR did give us anything to change our plan. If the patient is asymptomatic, it's okay, just we'll follow him. If the patient is symptomatic, that's different.
I agree with you. I hope we don't see a surge in TAVI for asymptomatic in the next few months.
But I think the guidelines now changed recently, only yesterday. And now they recommend to do TAVR for patient who is asymptomatic with severe aortic stenosis. Just yesterday. So you have a good reason to change based on evidence.
Exactly. If you go into deep, was in blind, no sham, which I agree that it's not an easy to do sham. And the other thing is, it was sponsored by the industry. And the last thing, it was implant hospitalization. It was not mortality, not a stroke. Just to let you know, maybe if you want to do it, dig hard into the data and then decide yourself. But I agree there is FDA approval yesterday.
I think the last comment, for those patients asymptomatic, for how long they will keep asymptomatic? If you follow the patient 1 year, 2 years, 3 years, so the picking of the patient early, maybe this is that make the difference between the strategy to treat like this patient.
Dr. Mohsen, in your case, I'll just keep it very practical. I'll let his quality of life decide. I want him to be well informed, then he'll decide when he needs it.
If you're going to do any more things, maybe cardiac imaging to look to see if there is any damage or not. I mean, something to justify move on forward.